The posterior fossa is fraught with dangers for the neurosurgeon. In this short presentation, we present three cases between 1st and 15th of Jan of this year of lesions in and around the cerebello pontine angle. We tackled them, and there was some success and some complications. The first case was a case of cerebellar hemangioblastoma. Mr. Joseph presented with features of increased intracranial pressure to another center where he had undergone a VP shunt. An MRI had revealed a left cerebellar intracranial space occupying lesion. He was taken up for surgery on 4th of January. A suboccipital craniectomy was done, though the petrous and the tendorium were both exposed. In view the preoperative diagnosis of hemangioblastoma. A transcerebellar approach was taken to the tumor. A very vascular lesion was seen, which was coagulated all around and excised en bloc. The histopathology was of a hemangioblastoma. The problem was the patient had post-operative vomits, which were very troublesome and which lasted for about 3 days. This is an immediate post-operative scan showing the resection cavity. The hemangioblastoma diagnosis in this histopathology report is also seen. The second case was a patient who had presented with severe headache. So this is not something you would expect in a patient of acoustic schwannoma, or more appropriately called vestibular schwannoma. This patient was evaluated with an MRI which showed a left cerebello pontine angle lesion with features suggestive of an acoustic neuroma. However, the tumor had bleed inside, and also the increased vascularity, which we will show in an MRI in the next slide. She was on antiplatelets, so we waited for 3 days. And on the 4th day, she was taken up. A left retromastoid craniectomy and tumor resection were done. The tumor was identified. It had a lot of vessels on the surface, and some of them were feeders into the tumor. So the individual feeders had to be cauterized and cut, though one odd vessel did escape into the brain substance. The facial nerve was anatomically preserved. The thrill was of excising a not so simple acoustic neuroma. The patient had a grade 3 facial palsy post-operatively, which improved to grade 2 by the time we discharged her on the 4th post-operative day. She could close her eye. First day, she had left-sided 6th nerve palsy, resulting in quite marked diplopia, which resolved in 48 hours. Also, the CT shows a small opposite hematoma, which fortunately did not have too much of clinical ramifications. These MRI sequences show the vessels which are sort of ensheathing the tumor. Post-operative scan is also seen, and this is the histopathology report. The third case was a patient with trigeminal neuralgia. He has been having symptoms for the past 20 years. He had gone to various institutions, had been recommended surgery earlier, had failed medical therapy, but finally, after failure of Ayurvedic treatment, he came to us for a surgical cure. An MRI was done when neurovascular conflict was not very classical. However, it was decided to operate upon him. He underwent surgery on 15th January. A microvascular decompression was done by a right retromastoid craniectomy. The superior cerebellar artery loop was found anterior to the fifth nerve, and it was impinging at the root entry zone. Each pulsation was tapping the nerve. Fat was harvested from the thigh and interposed between the artery and the nerve, and a sweater of fat was put around the fifth nerve. There were veins on the posterior surface. One of them was densely adherent and was not separated. The other bigger veins were moved away. The thrill was that the patient got relieved of most of his pain. He could now eat without problems. We had some spills also. The patient had a CSF leak, which required the placement of 3 sutures in the ward. And he complained that though the pain in the cheek, the forehead had gone, the pain on his nose still persisted. This is a post-operative CT scan of the same patient. You can see the fat around the fifth cranial nerve.